When people say, can we fix the NHS? I always respond by saying, you're asking the wrong question. The question should be, can we fix social care? Because if we fix social care, then we'll be in a position to fix the NHS.
Welcome to Health Chat, the UK's #1 health and social care podcast. We discuss the most important issues in the healthcare sector and the challenges our colleagues face from the front line of delivery to decision-making in the boardroom. Join me, your host, Dr Atif Ghaffar, as we speak with interesting people from across health and social care and bring you expert insight and discussion on the topics that matter most to healthcare professionals. Hello and welcome to Health Chat. I'm Dr Atif, and today we have a special guest joining us, Mr Tony Carlin. Tony is a registered mental health nurse with extensive experience in prison healthcare, forensics and mental health services. He's passionate about teaching and training, having delivered numerous courses on compliance, the CQC and specialist areas of health and social care. In addition to his mental health expertise, Tony has significant experience in adult social care, where he's worked at all levels, including as a registered manager. Tony, thanks for joining us.
Thanks for having me, Atif. Great to see you.
I want to take things back historically. So back in the good old days, when my folks first started out as GPs, going back to late 70s, 80s, way before CQC and sort of national regulation, when life was more simple. What happened? Where did the CQC come from? How long have they been operating for? Tell us some history.
The CQC were born in 2008 originally and officially took over their role in 2009. But where they came from was almost like a natural progression of regulation from the first attempt at nationalising regulation back as far as 2001, which I think was the Commission for Healthcare Improvement, followed by the Healthcare Commission. And the Healthcare Commission was in place until 2009. The Healthcare Commission was one of three regulators we had at that point. We had the Healthcare Commission looking after everything to do with healthcare. We had the Mental Health Act Commission looking after mental health services. And we had CSCI, the body that looked after social care at that time. And I think there was a general feeling that it was a very ineffective way to regulate. It was expensive, there was a lot of duplication, but it was also seen as being a lot of error. And in 2008, there was also the rumblings of what was to become a huge national scandal in the NHS that probably contributed to the death of the Healthcare Commission. And that was the Mid-Staffordshire scandal that came to light and really gained prominence in 2008. CQC were created in 2008 with the remit of shadowing the other three regulators whilst preparing to take over their function. And officially on the 1st of April 2009, the CQC became the regulator for all aspects of health and social care in England. And they have been in existence ever since. They've gone through a number of changes. They've gone through a number of frameworks where they regulated but didn't rate. There are still some services to this day that they don't rate. And they operate under the Health and Social Care Act 2008, which is the piece of legislation that has given them their powers and gives them the regulations with which they regulate all of us in the health and social care industry. And they've been evolving ever since, including the new iteration, which is the single assessment framework, which we could do a whole podcast on just on its own, and I'm sure we will at some point.
That's quite interesting. I remember I was working as a GP, assisting in an A&E department, and I remember they had a CQC inspection at a local hospital, and it was all a bit of drama, and everyone was very anxious at the time that we're having inspectors around. And I sort of laughed it off, saying, oh, there's absolutely no way we'd accept this in general practice. And I think about 2 years afterwards, we were then getting our first inspections. In terms of the climate of CQC inspections, can we sort of give a summary of who legally is regulated? So if you run a clinic or you're providing a service, who has to register with the CQC in broad terms?
That's a really interesting question, given the current climate that we're sitting in at the minute. There's a set of regulations called the Regulated Activity Regulations. That's the main regulations that govern all health and social care activity under the Health and Social Care Act 2008. And that has been around since 2008 with its update in 2014. But what we've seen in the last couple of years is a real change in the CQC's perception of what constitutes a regulated activity. Since COVID, there have been a lot of new types of services opening up. Innovation is driving the way healthcare is provided, using online forums, private providers providing very niche services in one specific area. And all these changes are coming together at a time that's causing the CQC a lot of confusion, let's call it. So their interpretation of what constitutes a regulated activity is often down to interpretation. And that in itself causes providers some areas of problem, really. What we find is there are providers providing activity that they traditionally don't have to be registered to provide, and they are now getting letters from the CQC telling them that they think the activity they're carrying out should be a regulated activity, and they either need to cease providing that activity or apply to become a registered provider. So we're going through a tumultuous time of change within regulation, and that includes those who are providing activity that once wasn't regulated but now is. And a real case in point was presented to me this week when I spoke at the conference of the British Association of Brain Injury and Complex Case Management. Case managers are a group of individuals who the CQC have more or less left alone for many years, but now they're finding that they're under pressure to become registered, and they're finding the registration process extremely difficult because the CQC don't understand the service they provide, and therefore interpreting what type of regulated activity they provide is causing a lot of people a lot of confusion at the moment. So it's a really difficult question to answer, and it really does have to be taken on a case-by-case basis. There are other issues across the sector that are driving this as well, and one of those is the drive to try and tighten up and regulate the beauty industry and the cosmetic surgery industry. There's a lot of controversy out there that there are people can do courses that take half a day or 1 day, and those people then become qualified to inject our faces with the most toxic substances known to mankind. And those people are providing those services in clinics that are not regulated by anybody. So there's a real drive to try and bring that under regulation as well. So we're going through this period of change, of innovation, of development across the sector, but that naturally brings with it some of these additional problems.
Certainly, I know some of these extensions of regulation are certainly welcomed by some healthcare professionals. Examples being the use of Botox for the face. I remember there were some clinics offering IV infusions for various types of sort of cocktails to make you feel better. And I think from a couple of years ago, that's now under regulation. So you have to be CQC registered for any IV treatment.
That in itself is still quite a grey area. There are still lots of clinics out there that are offering this that are not registered with the CQC. And to be able to administer an IV fluid, you only have to do a course that takes either a half day or a full day, a cannulation course. And the fluid that you're putting into the person has to be prescribed, but the cocktail of vitamins and minerals that you're putting into that fluid doesn't have to be prescribed. Vitamin B12 is one of the really common ones that people pay a lot of money for a 2-hour infusion. And the beautician who administers that infusion doesn't have to have a prescription for the B12, but they do have to have a prescription for the fluid that they're putting the B12 into. And this causes us a lot of problems. My background in social care makes me really passionate about this. If I had a client in a nursing home who required IV antibiotics, for example, and they couldn't have them in the nursing home. Throughout the country, we are starting to see 1 or 2 examples where this is starting to change, but generally speaking, you don't have IV infusions in a nursing home, despite the fact that you've got qualified nurses on site 24 hours a day. backed up by usually a good primary care GP practice. And if that person goes into hospital for an IV infusion, unfortunately, they're likely to be there longer than the 48 hours they need for the antibiotics. And an elderly person staying in hospital for 2, 3, 4, 5 or more days tends to what we call decondition. Their mobility will probably deteriorate. Their cognition will probably deteriorate. And they're also likely to suffer for pressure damage. And this is the controversial bit. And I don't want to upset my colleagues that work in the NHS, but in hospital, elderly people don't get cared for. They get treated. And people need to understand that treatment and care are two very different things. When that person comes back to their nursing home, they are going to require additional care from the GP and potentially the practice nurses and the nurses in the nursing home, and potentially have further admissions to hospital. If they'd had their IV antibiotics at their home in the nursing home, a lot of that could be negated. And with the pressures we've got on beds in the NHS these days, it's one of these areas that I think we could make a big difference by having such a simple change.
I think you mentioned some very, very important aspects then. Certainly it's crying out for that reform within the NHS that everyone's so desperate to see. We'll come on to that shortly when we discuss politics. Just in terms of, as you mentioned, that there's so many ambiguities and changes which occur, and it causes complete chaos. I know for a fact that there are certain types of treatment that aren't regulated, but as soon as you get a medic involved, they then have to be regulated for exactly the same treatment. And again, I think this boils down to certain loopholes in the law, if I'm not mistaken.
Yeah, I think one of the big examples I dealt with recently was for a GP who had an aesthetic and cosmetic surgery clinic, and he also provided private GP services from that clinic. And some of the activity that was carried out in the clinic was classed as non-regulated. And the example I had was he removed skin tags for cosmetic reasons. And the vast majority of the skin tags he was removing, he used cautery. So for those that aren't aware, cautery is where you use a diatherm, something that's really hot, to slice off and remove the skin tag. And while you're doing it, it closes the wound. And that's not a regulated activity. But then he started to find some of the skin tags required a little bit more. And he was making the tiniest of incisions to remove them and get the roots as well. But because he wasn't registered to provide surgical procedures, the fact that he had made perhaps a 1 or 2 millimeter incision to do the same thing, remove the skin tag, he was carrying out a service for which he was not registered. And the CQC somehow found out about this and sent him a letter informing him that he was now subject to enforcement action, quite serious enforcement action that could affect his entire business. So there's a lot of these examples that really need to be looked at in detail so that loopholes can either be closed or they can provide a much more common sense approach to the whole area.
Now, the CQC website in itself, there's a lot of information on there. So when people are at that stage, if they're not sure whether they need to register or not, that there is a wealth of information on the CQC website and the Mythbusters and obviously resources that you provide as well. Generally speaking, if you're wanting to start a new service and you need to register with the CQC, one general question, I guess, bit of trepidation, bit of anxiety, but are the CQC your friends or your foes?
That's a really loaded question, Atif, and one that could get me into a lot of trouble. I would have to say the CQC are your critical friend. That's the main purpose. And although I perhaps do have a bit of a reputation of being quite critical of them as a regulator, I have to say I am firmly in the school of thought that says we must have regulation. We must have regulation across the sector. It must be robust and it must be consistent. They are there to protect the rights of the people we look after. It's how they do that is what's under scrutiny really at the moment across the sector. Mm-hmm. So if you're asking me what are they there to do, are they your friend or your foe? I would say they are your critical friend, and perhaps they just need to brush up a little bit on what friendship means.
So where we've successfully registered with the CQC and bearing in mind what you just said about them being the critical friend, I'm sure there are lots of cases where they've been incredibly helpful, not only to get you successfully registered, but also support you through the process to end up having a flourishing clinic.
There certainly is, and I know personally numbers of people, huge numbers of people who work within the CQC who are passionate about driving improvement. And ultimately, that is what they're there to do. They're there to look after the interest of the patient, the individual, and they're there to drive improvement. And they do that very successfully in many cases. And we have seen a number of cases of organisations that have had enforcement action taken against them, but through this improvement process and through the processes the CQC take them through, they now operate at the highest level, delivering the highest standards of care to their patients. So what they do and their intentions are the purest. What we're now seeing them do is go through a period of reflection where they're looking at how they could improve that even further. That's one of the reasons why we're going through such momentous change at the moment.
That brings me nicely on to, let's talk about the effectiveness of the CQC in terms of its role, what they look for, and how they go about regulating organisations. When you mentioned earlier, you referred to lots of cases where people have successfully registered and they've received support and help from the CQC. I've had personal experience myself. I've helped certain clinics register successfully. And when you engage with them, they have provided really good, meaningful information that you can then implement and have a successful registration and support going forward. I think in my personal experience, a lot of it boils down to personal interactions with it. It's who you're dealing with within the CQC, within that specific interview, rather than the whole organisation as itself, very similar to how the NHS operates. People's individual experiences on a ward very much determined by who was on shift, who did things out of goodwill, and who's there to really support you because they see the greater good in it. Coming back to the very basics of the CQC, what are they looking for when they're wanting to regulate organisations?
What it comes down to, and I talk to providers about this week in, week out, and when I deliver the workshops about regulation and how to navigate the regulation process and the inspection process, I try and bring it back to the very simple basics. Everything we do within the health and social care sector, within a health and social care service, is governed by the regulations that are laid down in the Health and Social Care Act 2008, Regulated Activities Regulations. That's our foundation. That's what governs what we do. Within that, there are some other associated pieces of legislation that complement that, such as the Health and Safety at Work Act, the Medicines Act, the Misuse of Drugs Act, the Mental Capacity Act. So all these pieces of legislation tell us what we should do and how we should do it. When we create our policies, our procedures, the ways in which we work, what we as providers need to be doing is constantly reflecting on what we're saying. Is what we say we're going to do compliant with the regulations? Does it follow the law? That sounds very simplistic, and it is a bit more complicated than that, but at its basic level, that's what we must do. What I always say to providers is, can we reflect what we do back to the regulations? Can we prove that we are meeting the requirements of the regulations? What the CQC are looking for is evidence of that. My first day at nursing school, and I'm sure it was the same for you in medical school, I was told, if it's not written down, it didn't happen. No matter what I do as a nurse, or now when I'm advising clients, it must be written down. The CQC want to see evidence of what you're doing, how you're doing it, and they want to see evidence of how you're testing the experience of the people who use your service. Are you talking to your patient? Are you talking to your staff? Are you talking to the families of the people you support? Are you taking their feedback? And more importantly, are you learning from their feedback? The same when things go wrong, as they do in our sector. That will never stop. And what I always tell providers is, that's not something to be afraid of. Things will go wrong. Accidents will happen, incidents will happen, errors will happen. And what the CQC are looking for in those instances isn't always necessarily the problem itself. What they're looking for is, what did you do about it? First of all, actually, they're looking, did you recognize it? Or did it have to be pointed out to you? And what have you done about it? What have you learned from it? What are you going to do to try and make sure it doesn't happen again? So, in a nutshell, that's what the CQC really want to know. Do you constantly reflect upon your own practice? Do you make sure your practice meets the requirements laid down in the regulations? And do you listen to what people tell you about the services you provide? If I could condense what compliance and governance is, but if I could condense what the CQC do into a couple of short paragraphs, that would be it.
Mm-hmm. The task of the CQC by default is enormous in terms of the number of organisations that they have to regulate, the new organisations that they're having to register, the evolving complexity of services that they need to decide upon. It goes on and on. In your opinion, is the CQC adequately resourced, and are people trained sufficiently enough to ensure that their processes are effective?
No, they're not. They are not adequately resourced. My personal belief is they're not adequately trained. And the reason I say that is because a lot of the providers I speak to tell me that an inspector can come into their service and not understand what they are doing. And if the inspector doesn't understand the service they're trying to inspect, it makes the job much more difficult for both the inspector and the provider. And it makes it harder to guarantee a rating that truly reflects what that provider delivers. And this, again, isn't just a criticism that I have of the CQC. A lot of inspectors I've spoken to have said the same, that they might come from a social care background, but because of resourcing issues, they might find themselves inspecting a GP service or a mental health service or a clinic that they don't really understand what it is they deliver. And that makes it really difficult for them. Like every other organisation in the country at the minute, especially within our sector, the CQC have their own resourcing issues. They're also going through a major restructure. So funding, staffing, training, we could be talking about any organisation in health and social care at the minute, and the CQC are no different, unfortunately.
In the explosion of information in the digital age, I know for a fact that the CQC have changed the way that they monitor things, the way that they ascertain information and they access remote information, as opposed to organising lots of inspections, which used to happen at the beginning. How effective are they in terms of assimilating that information, monitoring things, and then selecting who then needs to be followed up with a physical inspection?
That's a process that's literally in progress right now. As part of implementing what they call the single assessment framework, the new method of inspection, a big part of it, the strategy that was published in 2021, talks about smarter regulation. It's one of the 4 pillars of the new strategy. And smarter regulation is very much about using innovation, using technology to be able to gather data and assess that data before they even cross the threshold. That's the term they always use. They must cross the threshold before they can carry out an assessment. Whereas now, under the new framework, they actually have the legal powers to carry out much of the assessment remotely by gathering data. The plans behind it, the thinking behind it is really good. I'm a big fan of the direction they're going in. What's happened, unfortunately, like with any government-backed IT infrastructure project, we've had more than a few bumps in the road. And the new IT platform, the provider portal, that was originally intended to help manage this huge change, currently isn't working very well. And it was launched a couple of months ago, but they're still going through very major problems. And those people who can log in and use it, it's got very, very basic functionality right now. So we're potentially, in my eyes, still maybe a year to 2 years away from realizing the full potential of the changes and the benefits we're going to see from the new framework, particularly in the IT side.
Mm-hmm. Would you see any benefits from having working parties that are representative of particular types of organisations working in sync with the CQC? Can you see that happening in future?
For me, that would be the dream. I don't work within the CQC. I'm an outsider, so I don't know what's going on behind the scenes in relation to that. But what I do know is I follow a lot of the big players on social media, particularly on LinkedIn, which is a fantastic platform. A lot of the big players in the national care forums, Care England, for example, NHS England, a lot of the big characters who are driving these organisations and leading the sector. And if the CQC sat down with these experts in those areas and talked and worked collaboratively, in my eyes, that would be the way forward. It's an area that I've always felt that the regulator doesn't do, and I can't understand the reasons. The reasons I've been told is that as an arm's length regulator, they have to be able to enforce. And there was a feeling that how can we enforce against providers that we've got close relationships with? So I think there needs to be a balance struck, but I think that balance needs to come more towards a much more collaborative approach with the sector, because nobody knows the sector like the people who are at the front end of it. And that's where I think perhaps the regulator is missing a trick.
Mm-hmm. So using the police force as an example, there's lots of community projects where the police will turn up and engage with members of the public, whether it's car theft prevention, that they'll bring cars and things to show the kids, where they explain to the public, look, this is our job, this is our role, this is how you can help us, how can we help you more? And there's a lot more sort of community cohesion. In a similar respect, do you think there's more that can be done between organisations and the CQC, taking a health group as an example and other independent bodies? You do a lot of educational programmes. Do you think there's any merits in bringing the CQC and these organisations together under one roof and having dialogue?
To me, that would be the dream again. What you've just described, I think, is the neighbourhood policing model. And I think in any country and in this country, we've seen the neighbourhood policing model work really successfully. So why not bring it into what we do? The CQC, in my eyes, they could improve their level of engagement with that. I understand their reasons for not wanting to do so. They're supposed to be an arm's length body that has to be able to, without conflict of interest, take enforcement action against providers where that's necessary. However, I still think there's a lot of opportunity there. I've spoken at 2 conferences this year, organisations I spoke with last year as well. Both those organisations have invited the CQC to speak at their conferences to help build relationships and understanding among their members. The CQC declined on both times because they felt it was a conflict of interest. And while I can understand their reasoning, I also think it's a missed opportunity to really try and help bring the sector together. At Health Group, we talk to providers on a daily basis each and every single week of the year. To be able to sit down and explain what the providers are telling us to the CQC would be really beneficial to the provider, to us, and I believe to the CQC as well. So on a personal level, I think it's a real missed opportunity. However, I do understand why the CQC feel that they might have some kind of statutory barriers in their way to be able to take that further. And hopefully, as they're going through a restructure and a change, that might be one of the opportunities that they pick up on.
Mm-hmm, mm-hmm. In a similar vein, providers who have indemnity, for instance, GP practices who are registered with MPS or the MDU, it's commonplace for the indemnity providers to actually hold workshops for its clients. So in a similar way, we pay the CQC to be registered and regulated. We're almost their clients and they're ours. And so I think there's definitely, well, there should be more collaboration, more discussion, more dialogue between organizations and the regulators.
I agree, but I think what we're asking for there is a change of the culture of what regulation is. And I think both you and I know that culture change is one of the most difficult types of change to effect. And because we're going through this very transformative time that we're going through in terms of health and social care delivery, in terms of regulation, and in terms of potentially seeing a new government soon, this might be now the time where everybody can take that opportunity to refresh that.
Let's talk politics.
Fantastic. One of my favourite subjects.
So it's very likely that we are going to have a completely new change in government.
Mm-hmm.
The CQC have been operating the way they've been operating under 14 years under the Conservatives. With potential huge change, what changes do you think culturally might occur, if anything, with the CQC? Are they going to continue doing the way things have been done for the last decade or so? What do you think ought to happen under a new government?
It's a really difficult one to answer because the amount of things that are happening at the moment is makes things quite difficult to predict. So, for example, just the week before the election was called, there was an announcement made by the Cabinet Office that an inquiry into the CQC has been ordered. What level that inquiry is going to operate at, we don't fully know yet, because as soon as it was announced, almost immediately the election was called. What we do know is the chairperson of North West London ICB has been asked to step away from her role there and chair this inquiry. So the person has been appointed, but we haven't got further than that. We don't have the terms of reference. We don't have the scope of what the inquiry is going to look at. The people I've spoken to across the sector do have a real hope that it is going to be a vehicle for change, that it is going to be positive, that it is going to engage all the stakeholders across the sector so that we can have a CQC 2.0 where we have regulation fit for what health and social care is today. Because what health and social care is today is a very different beast than what it was even 10 years ago. So what we're hoping is that this inquiry will be that vehicle for positive change. Alongside that, you've just intimated that we are likely to have a change in government. It's highly likely. You and I are not going to sit here and be totally partisan about it, but I think everybody accepts it's very likely we're going to have a Labour government as opposed to a Conservative government. If that's the case, we're likely to have somebody like Wes Streeting as the Health Secretary. And he has given us some indications of the direction he wants to go in, which is a bit of a change of direction from what the Conservatives have been doing, the previous government. But at the same time, we are also hearing that he's potentially constrained by the economic situation, not just in this country, but across the globe. Mm-hmm. So trying to guess how far he's going to go with reform and change is quite difficult. I would like to think again that it's an opportunity for positive change, but that's going to depend on how much he, as the new Health Secretary, talks to the sector and, more importantly, listens to the sector. We already know he's not afraid to butt heads. Mm-hmm. Some say he's picked a fight with the BMA already. But on a positive level, it shows that he's not afraid to make tough decisions. The proof's going to be in the pudding, and it'll be really interesting to see how determined he is to change the sector positively. And one of the things I'm really hoping for out of it is a much more cohesive approach between health and social care. My passion and background is very much in social care, and one of the things that I constantly shout about on every forum that'll have me is that when people say, can we fix the NHS? I always respond by saying, you're asking the wrong question. The question should be, can we fix social care? Because if we fix social care, then we'll be in a position to fix the NHS. And we must get those two parts of the sector working better together. The new CQC's new single assessment framework really lends itself to that, and hopefully any change in government we see will drive that even further. My personal belief in looking at it and talking to people across the sector for the last couple of years especially is that to see any change really take effect, I think we have to be realistic, and I think we're looking at a 5 to 10 year program to really drive forward the improvements that are needed. I don't think there's a quick fix, and my only worry is that people will be too impatient. Change is long overdue in terms of health and social care, but it's not going to be a quick fix. We are going to have to be patient, and we're going to have to come together as a sector to really try and drive that.
Now, historically, we've seen doctors go on strike, we've seen GPs go on protest. There's been a huge amount of turmoil within the NHS over the last few years, staff morale, all the issues to do with whistleblowing and many stories. Do you think the CQC has a role in alleviating some of those pressures and sort of negative attitudes?
Most certainly. You're right. I think what we've been through since COVID has been a time like no other since the foundation of the NHS itself. I've said this at a number of forums, and some people have agreed with me and some people have said I'm going far too far. But I think this is the biggest period of change we're going through as a sector since the formation of the NHS. The last few years have been really difficult. You're right, we've seen doctors, nurses, lots of different allied health professionals all take industrial action, which is really unheard of. Now we have to try and heal as a sector. And at my very foundation, I'm a nurse. That's what I do. I'm a mental health nurse. I grew up in the industry by supporting individual patients. To do that, I had to try and understand their issues. I had to try and understand them as an individual. And I had to try and, with them, come up with a plan of care and treatment. How am I going to look after them? How am I going to help them improve their situation? And even today, when I work as a compliance specialist, that's still the approach I try and take. At the very foundation, what is the individual problem? And how are we together, me and my client, how are we going to collaborate and try and come up with a plan of care to help them improve? And I would like to think that the CQC are in the perfect position to be able to drive that forward. What they've done with the new framework is bring out new standards, new quality standards, quality statements with which they're going to assess people. And what I really like, what I think they've done really well, is some of those quality standards are talking about, do we treat people with kindness and compassion? Do we have integrity? Do we look after the well-being of our staff? And to me, that's a much more positive approach to regulation than what we previously had, which I felt was too process-driven. So I think they've done a great job in putting the new framework together, and they did that by the consultations they had with the people in the sector. Hundreds and hundreds of providers across the sector took part in their consultations that resulted in the new framework coming together. So I'm hoping that they carry on that momentum and realise the power they have to really lead the sector out of this really difficult period that we're in. And you're right, you mentioned things like whistleblowing. As organisations, we also have a responsibility ourselves to try and improve that. We can't just rely on somebody like the CQC to do it for us. It has come out that there is a culture across the sector that perhaps isn't the nicest culture to have, and we have to be very open about that. It has resulted in some very tragic situations and cases across the country, and what we have to do is be bold enough to reflect on that and say, we must become different types of organisations. We must become kinder. We must recognise that we're working with human beings, not just the people we support, but the people who work for us as well. So I think as organisations, we have a big role to play, but I would like to think the CQC can take this opportunity now to take that by the scruff of the neck and really drive it forward.
I think you've ended things on a very, very positive note there. In this great tsunami of change, we don't want lots of destruction, but we want sort of formidable castles to be left at the end of it. Tony, thank you very much indeed. And we wish you all the best on all your educational and presentation exploits in the next few months. And like you, I'm very excited, anxious, a mixture of feelings about what to expect over the next few years.
As a newly qualified young nurse, I never thought I would use the phrase that I'm getting excited about the opportunities that governance now has for us. Governance and compliance weren't what excited me when I was a naive and idealistic young nurse. But you're right, I think the next couple of years is going to be really interesting, so I look forward to seeing what's coming. And thank you for the chat today.
Thanks for joining us. If you have any questions, feedback, or you'd like to learn more about how we can help your organisation, please don't hesitate to get in touch. Our contact details are in the description below. Don't forget to subscribe to our podcast for more episodes and updates. You can also follow us on LinkedIn, Facebook, and Instagram. Once again, thank you for listening or watching, and we'll see you soon. We are the Health Group. We work with the new and existing healthcare providers every single day, from private clinics to adult social care services and NHS trusts, to ensure all providers are compliant with regulations, have a culture of excellence, and are delivering exceptional care.